So we have more ADHD medication, we have more depression, more anxiety medication that's been diagnosed. Now we have younger kids who are coming on these medications. And you have people who, if you're asking your patient, do you have dry mouth, that's not an accurate assessment. You have to be using some modality to say, is the mirror sticking to the buccal mucosa, the tongue? Is the tongue glossy? Is there stimulated saliva when you flip down that lower lip? And if there isn't, there's a problem. If our patients are high risk, we should be assessing them. Do they have deep grooves? Are we disclosing them? Is there bacteria within the occlusal surfaces? If there is, put a sealant on it on an adult patient. That's not a sin.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Happy Saturday, everyone. Welcome into this special bonus episode brought to you in part by Voco. In this episode, I had a chance to catch up with Amber Auger at the Greater New York Dental Meeting. And after a little bit of light chit-chatting and catching up, we talk about risk assessments. Risk assessments are foundational to helping us get our patients into the state of health that they need to be in. And if you listen to that tip episode that we did yesterday, you'll know that the right products that are based on those risk assessments are crucial to our work. So in this episode, not only does Amber help you learn the assessments and how to do them, but she gives you some great options from Voco to help mitigate the disease and risk for your patients. I hope you enjoy this one. It was a great time doing it. If you have any questions, make sure you reach out to Amber.
A tale of two hygienists.
All right. I just hit the record button, so you don't have to say things you don't want to say. No.
I can say it all over.
No, it's fine. Listeners, we're just talking about Amber. Okay, so here we go. No, just
You
kidding.
were talking about me being intimidating. That's 5'3". female.
Yeah. So when I first met you, it was RDH under one roof in Chicago, I think, and we were doing something for Matt Crispine of the. Sorry, Matt. He doesn't listen to this anyways, but I think I messed it up. But it was a October Wisconsin oral health something. It's pediatric something awareness thing.
Okay.
And so what we did.
Oh, yeah, the sign.
Yeah, with the sign. Yeah. And we went around to all of everybody, and we said, hey, will you just say this one thing, and blah, blah, blah. And everyone said it, and it was great, and it was awesome. And I remember coming up to you, and we said, hey, you want to do this thing? And you were just so different then than you are now. And I don't think it's not like a good or a bad thing, right? We all evolve in our things.
Yeah.
I was way different back then than I am now, too, right? And now when I talk to you, you're driven, you know what you want. You know, the direction that you want your life to take. Mm-hmm. And not to say that you didn't probably have an idea back then, but
I didn't have an idea back then.
Kinda, right?
No. And it's been, when I went to a conference called Career Fusion in 2017, and my career goal was to become a Crest and Oral B rep. That was literally my goal. That was my goal. That was my stretch, big picture goal, because I didn't know you could be a speaker. I didn't know you could develop a brand. Influencer marketing wasn't big back then.
Yeah.
It didn't exist.
It kind of came on almost around that time, actually, probably.
And then when I got my role with RDH, now everybody was excited about it. And it was, who's this girl who's in her 20s who's doing this? And I've always taken the route of making sure I'm dressing professionally, making sure that my brand is good, because I feel like I was a part of the RDH legacy and making sure that I'm representing the hygienist well. So a lot of weight was
so interesting
on my shoulders as a 20-year-old. So I was still finding my role outside of the operatory while still being in the operatory, and learning how to navigate it with literally minimal direction. I had great mentors who pointed me in the right way, but now now I know who I am and what I want. I've learned that through trial and error and sweat equity.
Oh my gosh, I have so many thoughts about this. So let's talk about your dress, first of all.
Okay.
Not your dress you're wearing, but the way that you dress.
Sure.
Okay, so about the intimidating part. You are always put together. Anytime I see you, no matter what, if it's on a video, if it's whatever, you intentionally spend the time to look professional, like you said.
I'm glad you think that, because if you look at my Instagram, usually my hair's sideways. So.
Well, I don't do Instagram, so that's really great. So, okay. So here's the thing about that though, is you don't find that could be intimidating to the everyday hygienist who comes to some of these meetings, not necessarily in their sweats, but athleisure wear, or they call that. Like, you don't feel like someone like you who's like always like put together. Like, you don't. Oh, see, I would think that the everyday hygienist would be like, I can't pull that off, or like she's so unapproachable because she's like always like makeup's done, whatever.
No,
you don't think so?
No, not at all. And I wear minimal makeup compared to some other people, like. Minimal. I was just in the bathroom like, man, I should have put more blush on. I look a little pasty. Like, that's what I was thinking. And I'm wearing literal Band-Aids on my new boots thinking, why did I choose to wear new boots today? I've got Band-Aids all along my boots on the side. See. Yeah, that's what's happening. And, like, I'm wearing my $12 TJ Maxx jacket, balling on a budget. So I don't think I'm intimidating
As opposed to the hygienists that are
all.
just walking by, they do not look like they thought about the way they dressed.
They're here for CE. They're comfortable. I would be wearing the same stuff.
Okay, so going back to...
I'm representing a brand right now.
You are, so you
I
are
am my
representing
brand.
a brand.
And I'm representing my brand as Amber Auger. So I've chosen to, the outfits that I wear because I don't want to be showing different body parts. That's just who I am. And other speakers are different, and that's who they are, and there's nothing wrong with that.
None of them show body parts.
Some of them show body parts.
All right, we're getting off track on the body parts conversation. But let's talk about now being decisive and being definitive in the way that you speak. So what changed that got you like so direction oriented?
I will be 110% honest on answering this. 2019, I won the award of distinction with Sunstar and RDH. And that was a big career moment for me because my peers had chosen me to win that award. And literally days while I was on the show floor, I signed my papers for my condo. And my boyfriend of 4 years, who was my biggest cheerleader, decided that he didn't want the life that we had planned. So what happened through that is I hit rock bottom. I lost everything I knew. I had a brand new clinical job. Once I came back from RDH Under One Roof, they fired me for things that I didn't do. They couldn't even show proof of it. And at the end of the day, they were like, you're just not a good fit for this office. And that was probably the 5th time I had been hired as a circle and someone tried to make me a square. Yeah. In fact, RDH, my role with RDH is the only job that I ever had up until that point of getting it in 2017 that let me be me. They hired me and they were like, you can be you, and that's important. And we'll help guide you, but you make this role what you want it, which is such an amazing gift.
Yeah.
And what happened is 2 months after we broke up, I was really still devastated. I was in a really bad depression, and I got a life coach. So that's what really has allowed me to find my way.
You worked on it. I worked on it. Now, so all of these terrible things that happen, you're like, okay, well, I'm going to get through it. I'm going to do this, this, and this. Was the intention there that in 3 years or in 4 years, this is where I'm going to be? Or was it just, I'm going to work on me now, and this is where you ended up?
It was, this is where I want to be in 5 years, but let me work on my soul and let me work on what matters. Yeah. Because in the past, I've just waited for people to dictate my future. Sure. And then I said, well, what do I really want out of this? Like, I can always do clinical hygiene on the side, and let me not chase the money. What am I really passionate about? So
you work with a lot of brands. Mm-hmm. How has that kind of shaped your voice a little bit? Or vice versa? How have you impacted brands and their voice?
Yeah, I think when I first started, it was great because it was teaching me the structure of corporate structures and how they're different depending on the brand. Mm-hmm. And they also helped me, of course, build my own brand within them. Mm-hmm. Now it's different where I'm saying, hey, there should be a licensing agreement on this, or hey, just because you asked me to do a quote here doesn't mean that you can use that quote everywhere. So now the tides have shifted. I've learned a lot more about business. I've had people take images off my website and put my brand, my name on their website without asking. So now I feel like my role in the industry is to prevent that from happening to somebody else.
How do you find the good brand then? Because I've heard the horror stories like that before, and it's not just brands that do that, right? I mean, it's also like other speakers or whatever can take content. But how do you find someone, we have Voco on the program today, like that you choose to partner with?
Yeah. For me now, making decisions now is very different than the 2017 Amber. And I want to be a part of companies that allow me to be 100% me, but then also trust my opinion and let me take it in the direction I want to. So the amazing thing about Voco is they have been a part of my wheelhouse of products and a big champion of me since 2017. So a lot of the companies that I work with are long-term companies. The hard part is the brands are often really dictated by who's in that role. So there's been companies that I used to love working with that literally are not so fun to work with anymore because you have somebody that's different in the role and they don't maybe they do things a lot different. It's just like a practice owner where you love the office that you're in and maybe the owner changed or the dentist changed and now it's a totally different environment.
Or like the coaching system that the doctor subscribed to said,
Exactly.
hey, do this now. And then you have to like pivot and now you're like, oh, this isn't as fun anymore.
With a hygienist who maybe has not practiced in 40 years, right?
Yeah, exactly.
Yeah,
Exactly.
it's very
that's
different
interesting.
post-COVID. Yeah.
I never really thought about that. Not that a lot of brands, I mean, because Davita's been on the podcast. I think it was in that same Under One Roof 2017 when we were all talking. So she's been around for a long time. It's super supporter of hygienists, which
She is.
for me, the ones I want to work with are pro hygiene. They're not always talking about the dentist. They're not talking about, I guess even beyond that, they think about the patient, right? They think about the patient's needs, the patient's wants. They don't just wait for a marketing pitch, a new way to sell to the patient, right?
Right.
Which I think is something that Voco does pretty well for the most part.
They do very well, yeah. They do very well with that.
All right, so what are we going to talk about today? We have a whole, in typical Amber fashion, we have a whole slew of things we can choose from. Where do you want to start?
I think let's start with risk assessment with caries.
Let's do it.
Okay. So one of my things that I'm obsessed with is saliva. And the reason behind that is because I think we're missing a key component of saliva. We all know that calcium and phosphate come from the saliva, and that's going to help flush out all the toxins, it's going to help with digestion. But if you're seeing a patient who is struggling and says, I have a really sweet tooth, I can't get over it, where would you take that patient?
Okay, can I just tell you real quick?
Yeah.
Literally just had this conversation with my dad.
Really?
If he does not listen to this episode, I'm going to actually tell him to listen to this episode because we actually started getting into genetics a little bit. So I hope, hopefully we can come back to genetics in a little bit too, because maybe I'm wrong on what I told him, but I want to know your opinion. So a patient comes in with a sweet tooth. Is that that was your question? What do I do?
They say to you, oh my gosh, I don't know, I can't break this sweet habit. I'm constantly reaching for sweets or salt.
Yeah. See, so that's a tough one. I would probably start off with, can we replace it with something? Can we do a substitute? Can we lessen it? Kind of a reduction of harm, kind of let's lower whatever that threshold is.
Sure.
And see if there's any change there. Or compensate it with some sort of buffering agent. That's probably what I would try to do. But sometimes I'm like, I don't know. Like we've been talking about this 5 times now, and you aren't giving me anything new to work with. There's no new material here. Like, what do I do?
Right.
Right. That's hard.
First place I go is let's talk about the xerostomia. Because if you have a dry mouth, you're going to be craving sweets and you're going to be craving salt.
Oh, interesting.
So let's start there. And that's a really simple thing that we're missing as clinicians.
Craving salt because
you need to stimulate saliva. So naturally your body...
Oh, okay.
Yeah, it's subconscious. It's your body saying, I need hydration. I need something.
It's a trigger.
Exactly.
Oh,
it's sweet and salt because of that. Now, here's the downfall. If you have xerostomia, you're naturally going to be craving that, but you're never going to have enough salt. So your body is your taste buds are going to change with that, right? And now you're going to crave all this salt. When you have salt and you have sweets, obviously those are not super beneficial for your body. Within normal limits, sure. Yeah.
Well, it's also interesting though too, I think, because if you are satisfying whatever this craving is, you're constantly putting sweets in, you're constantly putting salt in, and you don't experience these xerostomia effects because it's always like you're always having enough saliva because you're doing the thing. That's, I think, where people don't understand what they're doing. Like it's a back to the subconscious thing. Like you don't mean to harm yourself. You're just accidentally doing it.
Exactly.
So you start with saliva.
So then I'm going to assess the saliva. And here's the other thing that many of us aren't thinking about. We know that younger patients are on more medications, but during COVID, the amount of patients that I'm seeing who've never been on a medication, who are now on ADHD medications through the roof, right? Especially millennials who are undiagnosed, female millennials who are undiagnosed with ADHD. It's popping up now. There's a wait list for it. It's impossible to get. So we have more ADHD medication. We have more depression, more anxiety medication that's been diagnosed. Now we have younger kids who are coming on these medications.
Yeah.
And you have people who, if you're asking your patient, do you have dry mouth? That's not an accurate assessment. You have to be using some modality to say, is the mirror sticking to the buccal mucosa, the tongue? Is the tongue glossy? Is there stimulated saliva when you flip down that lower lip? And if there isn't, there's a problem. So that is a root cause. I love to practice root cause hygiene. I have a certification called the functional RDH where we get into all of the nerdy things of let's treat the root cause instead of the symptom.
Yeah.
And it's really like functional medicine, but for the hygienist. It's trademarked. I'm super excited about it. But and I practice that way chairside because what kept happening to me is I would say to the patient, here are the signs and symptoms that I'm seeing and here's why this is happening.
Yeah.
So now the shame is gone.
Yeah.
Then the patient's like, oh, okay. So if you use a xylitol product, if you use this dry mouth spray. This is going to help alleviate that salt and that sweet need. And let's put you on, instead of an energy drink, let's put you on a water with xylitol in it, and it'll be sweet and it'll help kill bacteria and prevent it from growing.
Yeah. Well, it's interesting too, because I think that sometimes we jump into really complicated solutions as healthcare providers, right?
Mm-hmm.
We say, okay, here's the 8 like hoops to jump through, but really let's just do water with xylitol in it. Like there's something, there can be something so simple and so basic about helping our patients, but sometimes we overcomplicate it.
I agree.
But why do we do that?
I don't know. I think sometimes we maybe want to feel really important and want to throw like
the
whole we want to throw the whole kitchen sink at it.
Yeah.
Because often if you're not doing salivary testing and you're not measuring the baseline pH, if you're not proving that your method is going to work with this patient, you want to put them on multiple things so at least one thing works.
Which I think that like that shotgun approach of medicine has kind of been a problem in the past as well.
Mm-hmm.
Tell me more about the testing of the pH though, because so saliva production is a problem. That's kind of like one bucket. But if they have good saliva flow, then where do you go from that?
So they have good salivary flow and they have a good stimulated pH. They have, they don't have really destructive lifestyle habits. There's not a lot of alcohol. There's not a lot of caffeine products. There's not a lot of seltzer water. Then you can go in and they're considered a lower risk patient. I will tell you that most of our patients are moderate to high risk when we're actually looking. Yeah. And most of our patients have some level of xerostomia without knowing it. So when we measure and we're seeing that there is xerostomia, this is where we need to be thinking about what can we put in the patient's mouth that's going to help remineralize. Mm-hmm. So this is why I'm always choosing something with a calcium and a phosphate in it. And if it has xylitol, I really love it even more. So this is where we would be putting a fluoride varnish on our patients. One of the ones that I absolutely love is the Pro Fluoride with Voco. Amazing taste on it. It's pre-mixed. Have you ever opened up a varnish?
Kind of separated?
Yeah.
It's like you have your gloopy stuff on the bottom and then like that tree sap on top.
It's disgusting. Yeah. But do you know what most hygienists
and then you
do?
have to mix it.
Yeah. So when you mix it, what are you doing to mix it?
You're actually clumping it all in the good stuff.
You're taking the dry brush. The dry brush is going to literally absorb all of the fluoride ions. The first 2 teeth you're going to treat are going to have the most fluoride and the rest is not going to be properly mixed.
Do you have a solution for that? Because I heard
Isn't it
about
terrible?
a solution.
Yeah. The solution is you flip over. If you're using a varnish that is not pre-mixed,
which you
flip it
do,
over.
But
you flip it over and you use the end of the handle.
Were you the one that told me that?
Probably.
Because that'd be funny if it really was like you told me like that 4 years ago.
Probably was.
And I'm like, oh, that's a great solution. Yeah, but let me tell you your solution.
It probably was. Yeah.
That's funny.
I'm very passionate about it.
Yeah,
because I was working in an office where we didn't have choice over the formulary.
Yeah.
And every time I'd open, I was like, oh.
Yeah.
Yeah.
All right, so let's go back to our carrier's risk assessment. So we have salivary flow is one thing that we're assessing. Like what else are we assessing other than, I guess, like dietary as well?
Yeah. Dietary, you can also assess the red or orange complex bacteria with multiple tests out there. I love to do that because, for instance, if you identify that the patient has P. gingivalis hates xylitol. So then you can throw some xylitol at it.
That's
so now it's a roadmap. Yeah.
It's not that overcomplication we talked about.
Right.
Okay, so we have what other bucket do we look at with caries risk? We have dry mouth, we have like food, then behavior, I guess, behavior modification. But that can also be like just like eating, but also like brushing habits and all of that.
Biofilm.
The testing for the red complex, is there, I know this is a Voco thing, but like I'm always curious about.
Sure.
Is there a way to do that properly?
Oh, yeah.
Can you go into that for a quick second?
Sure. You want to focus on red and orange complex bacteria?
Orange. Yeah, let's start with the very basics.
Okay. We're going to keep it CE neutral here.
Yeah.
Okay. So there's 3 tests that are on the market that are pretty popular. The first is going to be oral DNA. Oral DNA is going to test at 10,000 counts of bacteria. They predominantly are going to recommend an antibiotic for that patient.
Okay.
Then you have your Microbiome Lynx DX, and these are all great products. They're all going to help you manage your patient chairside. The third one is a new one on the market called the HR5 test, and this tests at 10 counts of bacteria. Whether the bacteria is dead or alive on all of these, you're getting those measurements. But with 10 counts, this is where I get totally invested in because I do not want to put my patient on systemic antibiotics unless I absolutely have to.
Sure.
So when these levels are lower, I've actually cleared a ton of tests where they come in, the level is like a moderate level or a low level of P. gingivalis, and we can eliminate that. So if there's AA or PG in your salivary sample, they're automatically going to transfer their high virulence factor, aka the harder to kill bacteria, to other bacteria in the mouth, which is pretty alarming.
It's super alarming.
So you can't have a healthy mouth if you have AA or P. gingivalis floating around. Now, some are going to argue with me on that, And they're going to say, well, what if that patient doesn't have pocketing? Well, those pathogens are still there and they're waiting for an opportunistic opportunity. Doesn't mean that they need systemic antibiotics based off the level. So depending on their level, you can oftentimes get away without recommending systemic antibiotics.
And if you want to learn more about this, because I feel like that's a whole,
it's a whole nother, I can talk about it for hours.
Of
yeah.
this.
Yeah.
I mean, there are tons of resources for that, but that's a whole different podcast.
Yeah.
I want to talk about like moderate versus high. Like how do you treat a patient differently when they're moderate or high? Do you do extreme on your caries risk, or do you how do you treat them all differently?
They're going to be different based off of course, the level, and then also looking at patient compliance. So if they're an extreme risk, I'm going to want them to be carrying something with them throughout the day, like a xylitol mint or a spray or a dry mouth gel product. That's where I would go with those high-risk patients. And then the Canberra risk assessment is great to use for this because it's really your roadmap of what you need and when. But this is where we have to be thinking that if our patients are high risk, we should be assessing them. Do they have deep grooves? Are we disclosing them? Is there bacteria within the occlusal surfaces? If there is, put a sealant on it on an adult patient. That's not a sin by any means. It's actually a good thing, especially when you're doing it with the great technologies that are out there now with sealants. And making sure you're taking the time to obviously place them correctly. You don't want to be resealing your patient every 6 months. That's not a good thing to do. But
let's talk about aligner therapy, because clear aligner therapy is probably more prevalent than ever. There's, just as we're here at Greater New York, you look around the floor, there's the big one there, and there's some over here and some over here. It seems to be like the easiest solution nowadays is to do clear aligner therapy, but what are you seeing as far as the problems with it?
Oh, tons of problems. So what I'm seeing with the problems of it is, number one, you're not going to be able to get your saliva underneath the aligners to properly cleanse throughout the day. And then what's happening is patients are taking them out and then they're at work. They don't have time to brush, or they're snacking and throwing them back in, and now they've locked and loaded bacteria into, that's what's happening.
That's disgusting.
It is disgusting.
And so we see more like buccal pit. We see a lot more occlusal caries.
Exactly.
Are we also seeing proximals? Not necessarily more than the other.
I think it depends on the patient.
Yeah.
Yeah.
I think that's probably true. I mean, if you're doing risk factors, if you're a high-risk patient and then also having these behaviors, you're probably going to get more interproximal caries. But like if you're probably moderate, it just seems like we got more like flat surface caries before when I was doing like kind of our assessments and stuff.
Yeah.
So what do we do about that?
Well, another thing that we're also seeing too is flash, where if we have assistants who are, and I shouldn't throw assistants under the bus, it's not always assistants.
It could be also a hygienist who's never really had to take it off before. Or,
exactly. But if we have those those attachments that have extra composite around it, I say this because it happened in my mouth when I recently did Invisalign therapy, and I could see the plaque catching, and I was in my bathroom literally hand scaling a portion of it off, and I was like, this is terrible. Like, this is literally catching all of that bacteria. The other thing is the buffering capacity. If that saliva can't hit the enamel, you can't buffer.
Yeah.
So we're seeing more white spot lesions in my practice with aligner therapies.
What do you do for white? There's so many new things, but like, what do you like to do for white spot lesions?
So I'm always when I see patients that show any sign of flash, I want to put the Riemann Pro into the aligners at night. And that's an amazing thing that we can use with our patient. The Riemann Pro has xylitol in it. It's 1450 parts per million on that, hydroxyapatite in there. It also has some really phenomenal taste with it, so the compliance is really easy.
Nice. Yeah.
Unlike a gel product, it's not going to ooze everywhere, and there's no dyes to worry about, so I love that. The compliance is higher. And then there's no risk of any milk allergy.
Oh, that's nice.
Yeah, with the Riemann Pro. So I would do that, and then I would talk about brushing and home care and how they're cleaning the aligners. The biggest thing is how they're cleaning the aligners. So they don't know if they should be soaking them, and they're like, we heard we don't brush them, so you're not brushing them at all. There's a lot of like, oh, we don't want to do it wrong. So
what do you do? What is your expert advice on that?
Personally, I might get some hate on this, and I'm happy to take it. I love to just do a little hydrogen peroxide with water in it.
Oh, interesting. That's not what I thought. I thought you were going to go in a different direction. That's interesting.
I found with my aligners that was the best. The other products were leaving like an orangey hue.
Are you not allowed to use the ring cleaners, the little ultrasonic, like?
Oh, you could use the ultrasonic. Yeah.
I found that was an interesting one.
Yeah.
I actually just got a product from a demo product from somebody about that. I'm like, I don't have retainers, but
oh my gosh, send it to me.
Well, my wife, my wife is using it. So
good.
Yeah. So I mean, but that's okay. That's perfectly acceptable. If you have that already, don't mix it with your rings.
Right.
And then just whatever normal
I would just
solution.
do like a little baggie.
Solution.
Yeah, I would do a little baggie and
Just like you do in the ultrasonic.
Exactly.
Exactly. All right. Sorry, Boko. What did I miss?
So the Riemann Pro can be used daily. It's a phenomenal product, and patient compliance again on it is really fantastic overall.
Is it a weird question? Is it
Yeah.
twice daily? Are you allowed to use it twice daily?
Yeah.
Okay, because I feel like
You
sometimes
can
you're
use
like,
it twice daily.
okay, only a little pee, do this and do that.
Yeah.
All right. All right, so the last thing we're going to cover is clinical attachment loss.
Let's do
CAL.
it.
It's like
CAL.
CAL.
So I think there's this misconception all the time. Every time I lecture about perio, everybody's like, do you add, do you subtract? So I just want to remind everybody that the clinical attachment loss is also confused with the pocket depth plus recession. But your clinical attachment loss is apparent with the pocketing and with no gingival recession, or gingival recession with no pocketing, or both. I think it's important to know with your clinical attachment loss, this is a primary factor with the staging and grading. But oftentimes we forget that the staging and grading is not a treatment plan.
Oh, good point.
So you can have a patient that has clinical attachment loss of 6 millimeters. Immediately, that's going to be putting them in a stage 4, but that doesn't necessarily need to be scaled. But what we have to remember is that a patient who once had perio should not be put on a 6-month recare visit.
And why?
Ever. Because they've lost bone already. So why wait until they lose more bone to put them back on to a perio maintenance? The reason patients don't want to come back in for that is because they feel like they're getting the same treatment as a perio, as a prophy, versus a perio maintenance.
Okay, hold on.
So this
Now
is the
I'm getting-
difference.
Let's get it right. Okay, let's get into this then. How do you make that appointment? How do you differentiate that appointment?
Oh.
Because we see this every freaking day in our social media forums. Like,
Yeah.
well, the patient got mad at me. They left me a bad review again because they said it doesn't, and then they rejected the treatment plan because
Yep.
it doesn't feel different. Like, what? How do you treat it differently?
All comes down to education. So when you are working with your patient, you're identifying that they need scaling and root planing. You have two options. You can do same-day scalings, or you can turn that appointment into an educational appointment and not bill for a prophy. Now, most practice owners, and I can see it in your face, are going to say,
They're not gonna want
you
to."
have to make
Yes.
a certain dollar amount.
Yeah,
Okay, great.
can't skip that. Yeah.
If I need to make a certain dollar amount, my schedule needs to be diversified, and what I can do that day is offer them a salivary test. So now I've done the salivary test, so I already have money on that. I've done the films that we need. I've done the perio chart, and I've turned it into an educational moment. That is going to be my source of referrals back into the practice.
Yeah.
We have
That's
to move
smart.
away from the dollar amount and think long-term on the patient. So
Yeah.
now I've already have them engaged of, here's what it's different. Now they're not going to Google and seeing flap surgery and thinking, oh my gosh, I got to cancel. Or having the first experience with their hygienist of that day, telling them that they have periodontal disease when nobody has ever told them that before.
Yeah.
So that's the different model in that.
Are there any products that you want to talk about that at all? For that? I know we're like right up at time.
When it comes to clinical attachment loss, we can also be using light cure desensitizers, and Admira Protect has a great one that you can light cure. You don't even see it on the patient, and you can go right in and scale all of that calculus away without any sensitivity on their clinical attachment loss.
Which is magical.
It is magical.
And it's one of those things, like we use Game Changer way too often in this, I think, profession, but like it is kind of a game changer for the patient that has had every single dental experience be too sensitive, right? Every time. And the application is not that hard, and it doesn't take but just a second for us to do it. So, anyway. Okay, so if someone wanted to learn more about Voco's products, things like that, where can they head to?
Voco.dental.
Easy enough. And if they wanted to reach out to you personally, find out more about all the stuff that you have, where's the best place to find you?
AmberAuger.com or Instagram, AmberAuger RDH.
Awesome. Thanks for being here.
Thanks for having me. It was a blast. Bye.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.